Good morning, ladies and gentlemen. Today is the day of an interesting story of a 72-year-old male who has diabetes with its complications and especially urinary tract infections, and the clinical protocol will be presented by Dr. Ashish Pera, who is an assistant professor in the Department of Medicine. Ashish.
Thank you, sir. Welcome, everyone. My patient, Mr. R, resident of Una, Himachal Pradesh, a retired teacher by occupation, 72 years old male, and date of admission was 21st of June 2022, and date of demise is 24th June 2022, a duration of 4 days of stay in our PGI. The patient presented with increased shortness of breath from last 2 weeks, decreased urine output from last 10 days, increased swelling of bilateral lower limbs from last 10 days, and high-grade fever from last 2 days. The patient was apparently all right 2 weeks back to start with, when he had increased shortness of breath and limitation of his daily activities, and subsequently he had breathlessness even at rest, and there was marked limitation of activities, and it worsened from NYHA class 2 previously to NYHA 3 to 4. The shortness of breath was associated with cough with mild expectation of blood tinged frothy sputum 5 to 6 tablespoons per day, associated with orthopnea and PND. It was also associated with chest pain, left-sided, non-radiating, and increase on deep inspiration and coughing. There was no history of palpitation, stridor, or syncope. The patient also complained of decrease in urine output, which was previously 500 ml in 24 hours to less than 50 ml per 24 hours, which was high-colored and was associated with dysuria. The patient complained of increased swelling of bilateral legs below the knee, which was pitting and non-tender and was dependent in character. The patient was high-grade, intermittent, associated with chills and rigor, relieved with over-the-counter antipyretics, and the patient had history of easy fatigability, lethargy, decreased oral intake, and altered sleep due to shortness of breath during this course of illness. There is no history of jaundice, melena, altered bowel habit, joint pain, photophobia, seizure, or loss of consciousness. The patient presented to GMSH with above complaint and was diagnosed to have advanced azotemia and fluid overload, and was made to and referred to PGI, and he presented to PGI on 21st of June. There is past history of hypertension and diabetes from last 10 days. He was very non-compliant, and he was, although advised injection insulin, he used to stop and used to switch over to OHA or complementary medications. The patient was diagnosed with diabetic kidney disease in 2020 and advised for maintenance dialysis from 2021, but he rarely went for hemodialysis. The patient was under the follow-up of AEC for diabetic retinopathy, and the patient had cataract surgery done 1 month back. History of repeated admissions for this breathlessness is present in the history, and he had COVID infection in 2021, but there was no history of COVID vaccination. The personal history, he was occasional alcohol intake was there, and he is a non-smoker. In treatment history, he was on 4 antihypertensives. One of them was diuretics and a tablet linagliptin for his diabetes. Non-compliant, but the patient was already non-compliant to insulin or oral medications. There, on general examination, the patient was thin-built with generalized swelling, conscious-oriented, anxious look, air hunger was there with accessory muscles of respiration in use. There was right pseudofakia, and there was evidence of loss of appendages, skin appendages due to edema and neuropathy. The pulse rate was 112 per minute, blood pressure was 150 over 100, respiratory rate was 30, and SpO2 of 92 on venturi mass, and patient was febrile. There was pallor but no cyanosis, clubbing, lymphadenopathy, and there was bilateral pitting edema. JVP was raised and the patient was febrile. On respiratory examination, there was bilateral coarse crackles, bronchial breath sound was heard on the left infrascapular area, and per abdomen there was no free fluid could be appreciated. Cardiovascular, there was tachycardia, and in CNS there was diabetic neuropathy, sensory neuropathy below the knee. In clinical examination, the patient had anemia, which was 5.6 to 6.7. 2 units of blood transfusion was done. There was no leukocytosis, but there was shift to left and neutrophilia. The platelets were marginally low of 0.95 to 0.98 lakhs. The elevated urea creatinine level was 205, 9.4. There was marginal hyperkalemia also, 5.5 to 5.7. The PT and the coagulation parameters are normal. There was elevated CRP as well as procal level. In ABG, there was high anion gap metabolic acidosis. The blood culture was sterile. There was HbA1c of 8.8. There was hyperparathyroidism, that is 84.3. There was hypovitaminasis D. The ET aspirate during the hospital stay, there was 1 plus pus cell, yeast cell 1, and the negative for bacteria or hyphae. COVID RT-PCR was negative. Urine routine microscopy done on 18th outside showed albuminuria. There is glycosuria, 24 pus cells, granular cast. The urine culture, although was sterile. In ECG, on the day of presentation, it was only left axis deviation and sinus and tachycardia. But on 23rd, there was evidence of monomorphic ventricular tachycardia. Ultrasound kidney was right kidney, normal size kidney with raised echogenicity and mild ascites. Now, on 2D echocardiography, on 22nd, there was tachycardia, calcified aortic valve, LVH, trivial MR, no TR, and no regional motion abnormality. There was grade 2 diastolic dysfunction with ejection fraction of 55 to 60. And on 23rd, on the repeat echocardiography, there was a regional motion abnormality, and as well as the previous. For radiological, I will request Dr. Pankaj to give his expert opinion.
So we have two sets of HRCT for this patient. The initial one done almost 2.5 years prior to demise. So this HRCT was done in January 2020, and this is CT that shows that there is prominence of vessels bilaterally and there is blunting of the left CP angle. These are the mediastinal windows where we can see that there is bilateral pleural effusion, mild to moderate. We can also see that there are a few calcifications along the pleura. There was subcentimetric lymph nodes in paratracheal and subcranial location. There was no calcification within the lymph nodes. And on lung window sections, we can see that there is presence of interlobular septal thickening, as well as presence of fluid along the fissures. There are few areas of patchy GGOs and some basal consolidation and atelectasis is seen. These are changes of pulmonary edema. Then at the time of index admission, patient again underwent HRCT chest. And this is the scanogram from the CT chest, which shows that now the changes are much more marked. There is presence of bilateral consolidation as well as blunting of left CP angle. And now we see that there are no significant mediastinal lymph nodes. There is bilateral mild pleural effusion, and there is presence of bilateral consolidation. The left adrenal gland is diffusely bulky, though no definite focal lesion is seen in the left adrenal gland. These are the lung window sections where we can see that there is bilateral consolidation, both in upper as well as lower lobes. And this is area of GGO with interlobular septal thickening, which is known as crazy paving appearance, and is seen in both the lungs. We can again see that area of interlobular septal thickening with GGO giving a crazy paving appearance. And this is just to show the craniocaudal extent of the involvement, where we see that there is presence of disease bilaterally involving both upper as well as the lower lobes. So DDs of this pattern would be bacterial pneumonias, diffuse alveolar hemorrhage, and diffuse alveolar damage, and that will be dependent on the clinical scenario. Thank you.
Thank you, sir. Now coming to the course and management. This 72-year-old male with history of resistant hypertension, type 2 diabetes with diabetic triopathy, with a GFR of only 5 ml per minute, presented with shortness of breath, fever, decreased urine output. On evaluation, he had lower respiratory infection, features of lower respiratory infection, fluid overload, azotemia, hyperglycemia, and high anion gap metabolic acidosis. On day 1, he received a session of hemodialysis of ultrafiltered 2.5 liters and administered empirical antibiotics, insulin, and diuretics. For respiratory distress, he was started on NIV support with mild improvement, but the patient on day 2, after dialysis, during which 2 units of PRBC was transfused, and the patient required severe respiratory distress and was required to be intubated and put on mechanical ventilation. On day 3, he developed ventricular tachycardia and cardiac respiratory arrest, but the return of spontaneous circulation was achieved after the defibrillation and was started on injection amiodarone. He developed hypotension, which did not improve even with third vasopressor, and the GCS deteriorated. The repeat 2D echo showed regional motion abnormality. He continued to be hypoxic despite maximal ventilator support. sorry, and the patient received another session of hemodialysis post-cardiac arrest. On day 4, the patient developed cardiac arrest again, and at 8 a.m., and resuscitation measures were done, but the patient could not be revived and declared clinical dead at 8:43 a.m. on 24th. With a unit's final diagnosis of resistant hypertension, type 2 diabetes poorly controlled with diabetic triapathy, azotemia, fluid overload, heart failure with preserved ejection fraction, CAP, UTI, high and metal acidosis, severe anemia with hypotension, and cause of death was refractory shock, septic plus cardiogenic, and arrhythmia with type 1 respiratory failure. Now, coming to the database, I'll concentrate important on the investigation. There was anemia, neutrophilia with Sept to left, thrombocytopenia. There was non-normal coagulation. There was deranged urea and creatinine, uncontrolled diabetes, high iron metabolic acidosis. There was lactate was low, lactate was elevated, which showed decreased tissue perfusion, increased procal, as well as CRP. In urine, there was albuminuria of 3 plus, glycosuria, hematuria, pus, and coca in the urine. The radiology, as already described, ECG, LAD, and later to VT. 2D-co, calcific aortic valve, grade 2 diastolic dysfunction, preserved ejection fraction, and culture, urine and blood was sterile. ET aspirate was negative. Elevated PTH as well decreased vitamin D. Dengue scrub and malaria RDT was done, which was negative, and the COVID RT-PCR is negative. So I'll be discussing on 3 headings: that primary disease, presenting illness with complication, and the terminal events. So the primary disease, there is no doubt there was microvascular as well as macrovascular complication, and the all-cause mortality is 30% higher, and the most people die with cardiovascular disease. This is the United Kingdom classification for CKD. The patient fit into G5A3. Then coming to the aortic valve calcification is the predicts all-cause mortality independent of coronary calcification and severe stenosis. So the patient had, my patient had aortic valve calcification, which was an independent predictor for his. Next, the patient has resistant hypertension. He was on 4 antihypertensive. As per the definition, it is required to be 3 antihypertensive. One should be diuretic, as well as the maximal or maximum tolerable dose should be given. So what were the causes of resistant hypertension in this case? That is, first is poor compliance. Second is the patient has CKD. And the third, maybe as the patient has calcified aortic valve, so atherosclerosis with the renal artery stenosis, I'll be suspecting. Now coming to the presenting illness and complications. In our presenting illness, the lungs was involved, the heart was involved, and there was some urinary findings. Now coming to, if it is community acquired pneumonia, then what could be the etiologic agent? It may be bacterial, viral, tropical illness, fungal, or tuberculosis, which we see commonly. So coming to the bacterial infections, the many factors go for bacterial infection. That was acute onset, immunocompromised, high-grade fever, neutrophil Sept to left, increased procal, as well as CRP. There was significant bacteriuria also present, radiology also suggestive. But the against is that ET culture, there was no growth, and there was no leukocytosis. Viral, we are living in the COVID-19 era, so even a COVID-19 negative report doesn't rule out COVID-19. So secondary bacterial infection over a viral infection cannot be ruled out, and the patient had history of COVID-19 in 2021. So, but COVID RT-PCR was negative. Now coming to the tropical illness, all the patient has fever with mild thrombocytopenia, but the rapid diagnostic kit, which were highly sensitive, are negative. Now coming to the fungal, that is, many things goes for it also: immunocompromised, ESRD, type 2 diabetes, past history of COVID-19, heart failure, normal TLC, repeated admissions with empirical and antibiotic therapy can be given. But there is high-grade fever, there is pleural effusion, no serum markers available, and there is also elevated procalcitonin. TB, yes, because the patient is a CKD, ESRD, and there are high chances of tuberculosis, but this is a very acute history with high-grade fever and raised procal. So less likely it's a TB. So I'll keep a diagnosis of bacterial, viral, with a bacterial added infection. Tropical illness, less likely. Fungal, yes, but TB is very, very less likely. American Thoracic Society classification for severe pneumonia. It is 1 major of 3 minor, but our patient had 2 major and 7 minor. So he can be classified as severe pneumonia. Now, some diagnosis which can not be ruled out in this patient. There is in the radiology, there is evidence of so-called diffuse axillary hemorrhage also, and the patient had cardiovascular, that is advanced uremia. So the patient can present with hemoptysis. So, but against R, there is no obvious hemorrhage. But although there were 2 units of blood transfusion, there was no significant increase in the hemoglobin level. Now, very less likely it can be a septic emboli with endocarditis, but the radiology, 2D echocardiography and blood cultures all were negative. So this is less on cards. Now coming to the controversial topic about taking procalcitonin level in a CKD patient. But the baseline procalcitonin level is 0.6 plus minus 1.38. This is the baseline level of patient not on any hemodialysis. Even it decreases, the patient is on hemodialysis or peritoneal dialysis. And the CRP is also in the baseline is 21.33 plus minus 4.32. Our patient had a CRP 214 and procal of 11.6. So this I cannot negate in this patient. Now coming to the patient with heart failure with preserved ejection fraction, our patient had hypertension, anemia, diabetes, chronic kidney disease. So the patient had heart failure with preserved ejection fraction, and the prognosis of morbidity and mortality doesn't depend on what type of heart failure it is. It's preserved ejection fraction or reduced ejection fraction. It is similar in both the cases. So the annual mortality rate is 5% and 60% die due to cardiovascular events. Now coming to the urinary findings. The patient had high-grade fever, dysuria, significant bacteriuria, hematuria, and there was acute kidney injury. But there is urine cultures were sterile. But still then, I'll keep a diagnosis of urinary tract infection high on the cards. Second, renal cortical necrosis, but there is no imaging findings. There is no flank pain, but hematuria, granular cast, and normal-sized kidneys are there. So, although this can be a differential diagnosis, but not strongly taken. Coming to the bacteriuria, patient had cocci. So apart from urinary pathogenic E. coli, there are various cocci which can be responsible for the UTI in this patient, like Staphylococcus, Streptococcus, Enterococcus, and Enterobacter, as the patient had uncontrolled diabetes. Now coming to the terminal events, there was worsening of oxygen saturation and ventilator failure, and there was ventricular tachycardia and refractory shock. The causes of increased ventilator support, I'll say most commonly, most likely it's a progression to ARDS, as the PaO2 by FiO2 by Berlin's definition is 46 and is less than 100. Myocardial infarction, yes, there was regional motion abnormality, there was ventricular tachycardia, disposition of type 2 diabetes, hypertension, CAD with CHF. So, but I don't have the cardiac biomarkers to support my diagnosis. Massive pulmonary thromboembolism will be less on the cards because there is 2D echo was not suggestive. There is other parameters. I don't have the parameters. Arrhythmia. My patient had almost every parameter which could lead to arrhythmia, like diabetes, electrolyte imbalance, myocardial fibrosis, infarction, autonomic imbalance, coronary artery disease, inflammation, uremia, left ventricle function, repolarization, then left ventricle hypertrophy. So my patient had every risk factor for developing arrhythmia. For septic shock, I'll keep both the septic shock as well as the cardiogenic shock as the diagnosis. So type 1 respiratory failure, common acquired pneumonia, ARDS, cardiogenic pulmonary edema, and fluid overload. Everything predisposed the patient to type 1 respiratory failure. So my final diagnosis will be resistant hypertension, type 2 diabetes mellitus, diabetic triopathy, nephropathy, diabetic neuropathy, and retinopathy, heart failure with preserved ejection fraction, coronary artery disease, bilateral pneumonia, bacterial over viral, urinary tract infection, high anion cap metal acidosis, acute myocardial infarction, severe pneumonia, hypovenous T, secondary hyperparathyroidism. Cause of death is refractory shock with ARDS with type 1 respiratory failure and arrhythmia. So, as pathology is the Google map, ma'am, Uma ma'am will tell me whether I am going in a focused direction or I am a wanderer. Thank you.
Thank you, Ashish. Now you can come and join me here. So we have a very interesting case now. What we expect is that possibly all the organs are going to be affected either because of diabetes or because of superimposed infection. So yes, now we have comments. Yes, first from the nephrologist. Yes. So, Jasmina, would you favor a fungal infection or papillary necrosis or usual?
Yes, with uncontrolled sugar, ketosis, and fever, dysuria, and anuria, significant anuria, I'll consider disseminated mucormycosis as my first possibility. Other thing I would consider in this patient with resistant hypertension will be atherosclerotic renal artery stenosis with flash pulmonary edema. So disseminated mucor and RAS will be my first two possibilities.
So there are few points which need discussion. So if we are to assume that this patient had severe CAP, you see there is no evidence of DIC. The PTI and coagulation profile is absolutely normal. He had no shock to present with. So anybody having such severe degree of pneumonia, at least on radiology, and not manifesting clinically would be very odd. So one possibility would be HUS-TTP syndrome, because this patient had thrombocytopenia, he had renal failure, coagulation being normal. So one has to keep that possibility. Then the second thing is, what is the etiology of consolidation? So if you look, it is in the right upper lobe posterior segment, right lower lobe apical segment, and also on the left side. So most common, if you have to ask me, in an uncontrolled diabetic patient, I would still consider TB, and TB. We don't know why it has not been picked up on microbiology, but I would still consider TB in this patient. The features of invasive mucormycosis are not there, at least on radiology. There is no reverse halo. The consolidation, although it's there, it's not showing that degree of necrosis. So these are certain points that I would like to add to the discussion. Procalcitonin is a very dubious kind of investigation. It has a sensitivity and specificity of 70%. So in 30% of cases you may be right, you may be missing the cases, and in 30% you may be wrongly picking up. So I would not give much importance to procalcitonin, and there is evidence that procalcitonin may sometimes be elevated in patients with TB also.
See, there are two things which are going wrong with this patient. One is that he has got an uncontrolled diabetes, so there's no denying that you are going to see havoc in the organism because of this uncontrolled diabetes which he's having. But the point to consider is, what caused the balance to tilt and this patient to die? And the clue lies in the time when he got admitted, June 2022. That's the time when we were going through increased peak of COVID as well as influenza. The counts have not increased. In presence of CRF, I will not give any credence to any procal. CRP can still rise even in patients with viral sepsis. So whatever the X-ray has shown, the CT has shown, could all be fluid overload. This patient had received 1 or 2 sessions of hemodialysis, and there has been no changes in the clinical setup. So there has to be some infection, and I believe it is viral infection. 2 days back, Amanjeet has shown us that you can have an RT-PCR negative and the lung would still be positive. Why would Dr. Uma be behind? So she is also going to show us something PCR in the lung and in the heart, or maybe in the kidney. And if you look at what would cause renal failure or acute kidney injury, again you can bring in COVID-19. You can have heart failure with some kind of a myocardial inflammation lying there, absolutely normal coronaries, or in this case even maybe there is a plaque dysfunction also secondary to this viral infection. So I'll put my bet on either COVID or H1N1, and the clue to that is no rise in the total count and the thrombocytopenia which is happening.
Yes, sir. It becomes really very interesting that the diagnosis varies between a bacterial, viral, fungal, tubercular. I don't know, the treating doctor must be very confused. What will he do, what will he not do?
So while on the face of it, it all appears to be just diabetes related. However, in the 7th decade of life, when the patient has come with quote unquote pulmorenal syndrome with hemopsis, with a CT kind of suggestive of a DAH, with worsening renal failure, I would also like to bring in Goodpasture syndrome, which we know has a bimodal age distribution and does occur in the 6th and 7th decade of life.
Now we are moving towards non-infectious. Yes, Dr. Naveen. Anybody think of pregnancy also? I think that is the only diagnosis which is left now.
Just a small semantic correction. Resistant hypertension you usually give if the patient is compliant. If there is no compliance, probably a severe hypertension. And I think to the list of possibilities, there was some clue that there's a renal enlargement. I think need to look for histoplasmosis as well. The setting is there, CRF is there, diabetes is there, immunocompromisation. So histoplasma would be my bet, maybe tuberculosis.
What about pheochromocytoma? Adenal lymphomas, I said adenoma. Yes, somebody wanted to say. Yes, in that you want to. Are you still sticking with TB?
So the odd feature for H1N1 and COVID would be the CT findings, which generally in viral infections you would have diffuse kind of ground glass opacification, smooth septal thickening, which is not there. The point against fluid overload is that there is no feature to suggest pleural effusion. So at least on CT there is not there. So I would not give much credence to that. As far as COVID is concerned, we found that having thrombocytopenia in COVID was not that common. So that was an uncommon finding, actually, if you really ask me. So I would still stick with TB in this patient if you really have to ask.
All right, Vivek. So it means that the doctors are not to be blamed, you know, it's just a matter of how you perceive the things, because this is like a detective's work. You have at least 20 clues. Which clue is favoring a diagnosis? The absence of clue also in medicine, you know, favors a diagnosis. So I believe all of us are right in that sense, and then, you know, people should trust us. Yes, please.
So this patient had diabetes and hypertension of a fairly long duration, and 1 year back he was advised dialysis. So looks like that he was already in kidney failure in 2021, and he had been going on. It's not unusual for these individuals to, you know, carry on for months together with just drugs. So in such a situation, I think that the diagnosis, given the kind of circumstances that we have, the first diagnosis that we would think of, in addition to, you know, community-acquired pneumonia, would be tuberculosis. So I would also favor a diagnosis of tuberculosis, and the kind of because he has had COVID-19 also, so of course he would be predisposed to develop superimposed other infections.
Yes, anybody? I think I can see a senior student from nephrology.
Good morning, everyone. He had two flange of illnesses. One is diabetes and its complications, and the other one is the infection per se. With the chest X-ray findings, CT findings, and with adenomegaly, as many of the consultants already has told, a possibility of TB bar histoplasmosis has to be considered. The other one is for the CKD5 profile, the PTH level is so low. It is on the very lower side. So a possibility of adynamic bone disease, I don't have any calcium phosphorus values, but a possibility of adynamic bone disease because alkaline phosphatase is also on the normal side, or a multiple myeloma has to be considered. But ICAL is normal, even though there can be discordance between the calcium levels and ICAL. So that can cause, in the presence of MBD, that can cause CADs, that can accelerate the ACS, and that can precipitate myocardial infarction too.
But I could see the aortic calcification, the dense aortic calcification on the valve as well as the aorta. I think Dr. Pankaj has not mentioned, but if you look at the CT scans, you can see very dense aortic calcification, both in the thoracic aorta and the abdominal aorta. In fact, there was a ring-like calcification. I don't know what was it in the right low lobe. You can have a review of that, and maybe that Uma would show us or not. I am not too sure about it. Yes, anybody else? Yes, Dr. Sanjay Badada. In fact, I am very happy that Dr. Sanjay Badada is there, and he would give his comments on at least the definite issue, which is diabetes and its macro and microvascular complications.
So actually diabetes with the 10 years duration of diabetes CKD. So I believe the most common cause in addition to infection is some coronary artery disease that is very common in the sudden death, and because of this coronary artery calcification is going hand in hand with this peripheral artery calcification. So that is high possibility. And the pheochromocytoma is very, very unlikely because there is no such history, but this given case it is possible, but very unlikely.
Yes. Ashish, now you want to add something here.
There was a very good comment about adenomatous bone disease. The patient had undergone, for that he was somewhat investigated in 2021. In that there was no MBAT, there was electrophoresis was done, that was negative, there was no MBAT, but alkaline phosphatase was normal. So I also was searching for this calcium level. What was that? It was not available, unfortunately. Now coming to the tuberculosis. Yes, there is can be tuberculosis superadded bacterial infection this time, because I cannot rule out, because there is mild pleural effusion and there is also immunocompromised. The patient had this CKD also. So this time the patient had bacterial infection over a past patient may having harboring a tuberculosis from pretty long time.
Thank you, Ashish. Now I hand over to Bhuma to show us. Maybe it's a problem.
Thank you, sir, and a very good morning to all. It seems like that we are looking at a disease, its disease progression, the basic disease and its complications. So Dr. Ashish made it very simple, although to me when I started looking at the slides it was not very simple. But it turns out that it is the basic disease, its course and its complications. So this was a 72-year-old male. Usually we do not get autopsies in such age groups, usually 60, 65. This is one of the rare cases. And who had uncontrolled diabetes and hypertension for a long duration with diabetic triopathy and community-acquired pneumonia. This was a partial autopsy. The brain was not examined, so I won't be able to comment on the degenerative changes in the brain. The pericardial cavity on autopsy, the prosector has mentioned that around 60 ml of straw-colored fluid was there. However, the pleural and the peritoneal cavities were within normal limits. Now, since this patient had a history of diabetes, long-standing, I would start with the main organ. So go with the basic disease, its course and complications. So this is the pancreas as seen here. It's not very bulky or not even very fibrotic. It's maintaining its lobular architecture. The fat is also preserved. And on microscopy, this also shows that the endocrine as well as the exocrine pancreas is well visualized. In the islet cell, one can see this pale eosinophilic material. This is the Mason's trichome stain, which shows these islet cells, which shows this pale blue material within the islet cells, but there's no significant increase in the fibrosis or any insulitis or any pancreatitis as such. And on doing, this is the higher magnification to show this another islet cells with deposition of this pale eosinophilic material within the ILSS, which was congophilic and did reveal apple green birefringence, suggesting it to be amyloid deposition. Now, consequence to this basic disease, this patient predominantly had renal involvement, and these are both the kidneys. Although the radiology mentions enlargement of the kidneys, but the kidney weighed only 200 grams, both the kidneys, which should be usually around 300 grams or maybe more. And as we see that the aorta shows complicated atherosclerosis in the term of calcification, ulceration over the aorta. The kidneys are small, they're contracted with multiple superficial scars and small cortical cysts measuring around 5 millimeters to maximum in 8 millimeters in diameter. There is fine granularity and some blotchiness over the surface. However, the capsule could be easily stripped off. Now, this is a closer look of the right kidney. Very fine granularity, no pinpoint hemorrhages and superficial scars with increase in the intrapelvic fat, which is better appreciated on this cut surface. Small cortical cyst just beneath the scarred areas. No focal lesions. The renal papillae appear normal, no papillary necrosis, and there is no other focal lesion. The corticomedullary junction is also distinct, although the cortex is relatively thinned out. This is the left kidney, again showing the similar features, superficial scars, granularity, some cortical cysts, increase in the intrapelvic fat, and no ulceration of the pelvic lesion lining was also seen. Now, this is what the microscopy of the kidney looked like from both the sides. We had these depressed cortical scars going into the cortex, surrounded by the moderately dense lymphocytes, some preserved tubules, as well as marked degree of interstitial fibrosis. Now, point to note here is that around 50% of the glomeruli were showing sclerosis. Some of them are seen to be preserved with lobular accentuation. There is a PA stain to highlight this cortical scar. the preserved glomeruli and the sclerotic glomeruli with tubular interstitial fibrosis. The Mason's trichome brings out the fibrosis better and the sclerotic glomeruli well. So nearly 50% of the glomeruli are sclerosed. However, the remaining glomeruli do appear little accentuation on the lobules. This is a higher magnification to appreciate the sclerotic glomerulus, moderate degree of interstitial inflammation. One point to note here is that this inflammation was mostly localized to the areas where there was increased fibrosis, and the preserved glomeruli did show evidence of intraglomerular as well as periglomerular fibrosis, and there is extensive degree of crowding of these glomeruli, which is highlighted in the PA stain, and this fibrosis is also delineated better on the PA stain, along with tubular atrophy and thickening of the basement membrane. Another photograph highlighting the same, the sclerotic glomeruli, fibrosis, sclerotic glomeruli seen as these pale blue masses in the mesons. Now, on the closer look, the glomeruli showed varied morphology. This is one of the glomerulus which shows this kind of mesangial expansion and focal increase in the cellularity with diffuse, almost diffuse basement membrane thickening. The other glomeruli showed this kind of highly nodular deposits around the capillary loops, along with periglomerular fibrosis and some aneurysmal dilatation of the capillary at the periphery. The PA stain highlighting this kind of nodular proliferation of the glomeruli with increase in mesangial matrix and some cellularity. And this nodular hyalinosis is also well appreciated in the PA stain. This is a photograph which shows this crowding of glomeruli, and the glomeruli showed this kind of eosinophilic nodular lesions surrounded by these cells and patent capillary loops, confirming to the KW lesions of the diabetic nephropathy class 3, along with the wrinkling of the basement membrane at the periphery with periglomerular fibrosis, suggesting it to be both hypertensive as well as diabetic nephropathy changes. A higher magnification again appreciating another KW lesion, which are in the process of formation of big size nodule from small to, however, there was no capsular drop seen, and this is PS positive, and on mesons it was pale blue in color. A PA stain again highlighting this variety of lesions in the glomeruli, increase in the matrix with basement membrane thickening. Now, point to note here is that the tubular basement membrane is also markedly thickened, along with interstitial fibrosis. Now, this is to say that the ischemic changes were much more prominent than the diabetic changes in this kidney. Some of the preserved glomeruli also showed increase in the mesangial matrix with patchy basement membrane thickening. Now, after this, we performed the electron microscopic studies, and it did show irregular basement membrane thickening. No subepithelial or subendothelial deposits were seen. The podocytes, though, seen very few, but they were preserved, and the basement membrane maximum was 1500 nanometers against a normal thickness of 430 nanometers. So it was markedly thickened. The medullary compartment did show variety of cast, varying from hyaline cast to some granular cast, highlighted on the PA stain, and the Mason's trichome brings out the interstitial fibrosis with tubular atrophy. Another photograph, panel of photograph to show this granular cast, highlighted on this hyper magnification and collection of this predominantly lymphocytic infiltrate within the medullary region. Now let's come to the vascular compartment. Now all types of vessels showed changes from arterioles to the small size arteries to arcuate arteries. If we see here, there is marked fibrointimal hyperplasia with medial hypertrophy and arteriolar hyalinosis in this kidney, accompanied with interstitial fibrosis and tubular atrophy. The arcuate arteries did show intimal proliferation, reduplication of elastic lamina seen on the elastic von Giesen stain, and PA stain bringing out these fibrointimal hyperplasia. Now let's come to the next organ which this patient had major problems. The heart weighed around 440 grams. It was overweight, almost 120 grams overweight. It showed prominence of the left side indicating left ventricular hypertrophy. There was some increase in the fat and grade 3 atherosclerosis in the aorta. This is at views from the posterior aspect. No focal lesion could be seen, and heart was very firm in consistency. This is the right inflow tract. The right atrium is dilated. There was no thrombi in the auricle. The tricuspid valve was normal. The right ventricle wall, however, was thickened, and it was difficult to open. The pulmonary artery also showed some streaks in the lumen. The pulmonary valve was unremarkable, and the wall thickness measured around 6 millimeters, which is an indication of right ventricular hypertrophy. The left inflow tract shows normal mitral valve, though there is some atherosclerotic changes. Some whitish areas could be seen beneath it. The important finding was this subendocardial pale region, which was seen in the left inflow tract, which was extending not more than less than 1 centimeters in diameter, so does not qualify myocardial infarction per se. And this is the left outflow tract, which shows narrowing of the ventricular cavity, and both the papillary muscles are involved by these pale gray areas, which indicates ischemic changes or subendocardial infarction. This is the apical view to appreciate the concentric left ventricular hypertrophy, and all the coronaries dissected did show evidence of atherosclerosis. However, the luminal occlusion was only noted up to the tune of 70%, maximum in LAD, followed by left circumflex, which was seen around 3 centimeters of its origin. Now let's see the coronaries. This is the LAD, a higher magnification of the same, which shows a lipid core. Now still the lipid core is active. However, the plaque was stable by this fibrous cap. There was some evidence of calcification as well. The left circumflex nearly around 70% of the occlusion with the lipid core, and the right coronary was the most patent, though it also had atherosclerotic changes. This is what the myocardium looked like on a low power magnification. We had diffuse mild interstitial fibrosis with preservation of the myocardium essentially. The Mason's trichome highlighting the fibrosis running through the myocardial fibers, and the elastic stain highlighting these deposition of elastic fibers, suggesting it to be little older duration. Some of the areas, however, especially close to the papillary muscle, did show moderate degree of interstitial fibrosis, almost replacing the myocytes and causing its atrophy. And this fibrosis is highlighted by this Mason's trichome strain on as blue in color. Focally, there was myocyte atrophy accompanied with myocyte hypertrophy. Now, at this point of time, I was even thinking whether this patient is suffering from ischemic cardiomyopathy. However, the ejection fraction is preserved, so I cannot label it as histologically just like ischemic or diabetic related cardiomyopathy. And if we see this Mason's trichome strain, besides fibrosis, the intramural vessels showed changes. So they were having eccentrical proliferation of this intima as well as thickening of the media. And this is a section taken from the papillary muscle, which again shows moderate degree of fibrosis, myocyte atrophy accompanied with hypertrophy, and the elastic stain highlighting deposition of these multiple elastic fibers in these areas, suggesting it to be a chronic nature. Again, another section from the left ventricle, which highlights this thickening of the endocardium, fibrosis, and some of the areas showed myocyte vacuolization in the subendocardial location, suggesting subendocardial ischemia. Now let's come to the vessels. All the intramural vessels in the heart showed this kind of changes. So you have fibrointimal proliferations, outpouchings of the vessels, and marked medial hypertrophy. Normally, we don't see such thickened intramural vessels in the heart. They're hardly visualized on low power. Now, these were standing out on a low power. This is suggestive of diabetes-induced changes in the heart, although not amounting to diabetic cardiomyopathy. In the right ventricle also showed some kind of outpouchings, although not significantly enough to call it it. And then there was evidence of some fibrosis and vacuolization in the subendocardial myocytes. Now, since we are talking about vascular changes, I'll complete the vascular compartment of the lungs as well. This is a section from the lung. If we see it on a lower magnification, this is elastic von Giesen stain. All the arteries in the lung were very, very prominent. And this is what the vessels of the lung look like. They were showing marked medial hypertrophy, fibrointimal proliferation, and the concentric laminations. So all the arteries in the lung up to the, from SNR level to the major pulmonary artery showed this kind of changes. See the thickening of the vessel wall with narrowing of the lumen. A high power magnification to appreciate this fibrointimal hyperplasia and medial hypertrophy, well highlighted on the elastic stain. And a panel again to appreciate the changes in the pulmonary arteries in the lung. And this is a section taken from the hilum region. It shows pulmonary artery again showing this fibrointimal hyperplasia, which should not be seen normally, and it's an indicator of pulmonary arterial hypertension. Now, the additional feature in the lung was this. This is the relatively normal preserved area, which was very focal in this lung. These are the normal septae. And this is what the septae in the lung looked like. The septae were broadened by this diffuse capillary proliferation, and the alveolar spaces were filled with this inflammatory cells and pulmonary edema. And this is on a high magnification. We see a cord-like, double cord-like capillary proliferation, which are all congested in the alveolar septae, suggesting pulmonary capillary hemangiomatosis due to passive venous congestion. And this is the elastic von Giesen stain, again the intra-SNR arteries, very prominently seen, and diffuse capillary proliferation within the alveolar septae. In addition to that, focally there were collection of these hemosiderin-laden macrophages, which is also seen within the spaces as well as within the alveolar septae. And some of the areas showed this collection of macrophages within the alveoli, highlighted as blue around Persian eye blue stain. And these eosinophilic structures are corpora amylaceae, which are nothing but degenerative or age-related changes. Now let's come to the next organ. That's a complex of slice of liver, the slice of spleen, and part of pancreas. So the portal vein dissected did not show any thrombus or dilatation. The spleen was, however, diffluent and it weighed only 125 grams. The closer look of the liver, no focal lesion, but for alternate pale areas and some dark areas. Another view to show that there was no focal lesion or any thrombus in the IVC. This is what the liver looked like on no magnification. The portal tracts essentially were normal, but for occasional portal tracts showing this kind of porto-porto bridging and mild inflammation. There was areas of centrizonal congestion and hemorrhage, and the reticular framework was maintained, no increase in fibrosis or perivenular sclerosis or pericellular fibrosis. A higher magnification to show the normal portal tract and microvascular steatosis focally, which was seen in this liver. A further higher magnification of one of the portal tracts showing mild inflammation, occasional bridging, but no steatosis or steatohepatitis and no increase in fibrosis in the liver. The spleen showed thickened capsule with focal inflammation over the capsule. The red pulp was opened up. There was opening up of the sinusoid with congestion. And in addition to that, very occasional, this multinucleated cells could be identified in the spleen along with clusters of erythroid cells, suggesting extramedullary hematopoiesis. And of course, there was increase in the iron in the spleen as well, as seen as blue in color on Persian blue stain. Now let's come to the main seed of pathology which took away this patient from us. The lungs weighed 2100 grams. It was almost 3 times the normal weight of the lung in an adult. And it shows that the pleura was adherent and thickened on the left side. The right side also shows lustreless pleura. And there was some nodular feel to the lung, better palpated than seen. This is as viewed from the anterior view. So again, you see the adherent pleura on the left side with some nodular lesions, which were better felt than seen, involving diffusely the entire lung parenchyma, and the lungs were diffusely consolidated, very firm to feel, giving it a liver-like consistency. This is the cut surface, again highlighting diffuse consolidation of both the lungs involving all the lobes with intervening these hemorrhagic areas, which were more firm to feel on gross examination. Another cut surface to appreciate these hemorrhagic lesions, and one of the lesion was showing this pale outline, which was seen only on one of the lobe. This is what the lung looked like on the low part. This is a section from the left lung, which shows markedly thickened pleura with organized pleuritis. And you see the pleural artery, which is very, very thickened with medial hypertrophy. And all the alveolar spaces in the lung parenchyma were filled with this dense inflammatory infiltrate, accompanied with hemorrhage and pulmonary edema. This is on the higher magnification. So alveolar spaces were filled with acute inflammatory infiltrate, admixed with some histiocytes. Some of them do show phagocytic activity, accompanied with nuclear debris. Further higher magnification to appreciate the nature of the inflammatory cells. Neutrophils predominantly, some histiocytes and phagocytic activity in some of the macrophages, engulfing these nuclear debris and some dot-like structures in between. The bronchial tree was also, of course, diffusely involved with this acute inflammatory infiltrate, accompanied with fibrin. And some areas showed more of fibrin than inflammatory infiltrate, highlighted on Marshall scarlet blue stain as red in color, seen here also. The lesion which was seen in the left lung, which was subpleural in location, showed this kind of morphology. So there was breaking down of alveolar septae, forming micro abscesses, which was rich in neutrophilic infiltrate. And this is the PA stain highlighting that there was no fungal profile seen in this lung. On a higher magnification, these dot-like structures could be seen within this infiltrate and within the macrophages, which was positive as on gram-2 stage, suggesting it to be gram-negative cocobacilli. And this is under oil immersion. These cocobacilli could be seen both outside as well as within the histiocytes, highlighted as red in color on oil immersion stain on gram-2 stain. Rest of the special stains, including PAS, AFB, and gram stain, were non-contributory. Now, due to this diffuse necrotizing inflammation, the pulmonary arteries and veins showed secondary vasculitis in the form of transmural inflammation, lifting up of the intima. And some areas did reveal pulmonary edema with deposition of this pink eosinophilic material. better seen in these photographs. So pink, bright eosinophilic material lining the alveolar wall accompanied with hemorrhages, which is brightly PS positive. A higher magnification to appreciate this fibrin and brightly PS positive hyaline membrane in this lung. And very focally, there was some scarring with adenomatous transformation, injury to type 1 pneumocytes replaced by type 2 pneumocytes, and focal squamous metaplasia of the bronchial lining. Now, focally, the changes in the arteries were very, very florid, giving it like a plexiform lesion appearance, which was described way back in cases of chronic rheumatic heart disease in severe mitral stenosis. So this is what the recanalization of the vessel lumen with almost near total occlusion of the arteries in the lungs. In addition, focally, there was evidence of osseous metaplasia. Possibly, patient is hyperparathyroidism, maybe because of that, or age-related. The adrenals showed depletion of the fat, but there was a focal collection of lymphoid cells, which is highlighted on this higher magnification, but there was no significant adrenalitis. The thyroid showed normal morphology. Unfortunately, parathyroids were not sampled, so I cannot make a comment on that. There was no evidence of polyendocrinopathy, though. The GIT was essentially unremarkable. So the final autopsy diagnosis in this 72-year-old male who was having an uncontrolled diabetes and hypertension with diabetic triopathy and community-acquired pneumonia is diabetic nephropathy class 3 with IFTA score 2 and interstitial inflammation score 2, arterio and arteriolonephrosclerosis score 2. There is biventricular hypertrophy with microinfarcts, mostly subendocardial in location in the left ventricle. Grade 6 atherosclerosis involving the aorta, the entire aorta, and the coronaries, predominantly left anterior descending and circumflex. Features of congestion with pulmonary vasculopathy and passive venous congestion highlighted in the form of pulmonary capillary hemangiomatosis and hemosiderin-laden macrophages. Bilateral necrotizing pneumonia with diffuse alveolar damage and features of shock in the liver. Thank you so much. Though this patient had seen green pastures of life, he could have survived more. Though being a teacher, he was a very poorly compliant patient. Thank you so much.
Thank you, Ma. Now please come and join me.